go ahead. So, good afternoon, everybody. I'm going to present part 2 of the Management of the Dizzy Patient Case Studies lecture. The first lecture, we went through 5 cases. We're going to proceed from there. So this is a 35-year-old female attorney who presents 1 week after the onset of acute vertigo. 1 month prior to the evaluation, she developed a left oral fullness, a sensation of water in the ear, as well as ringing that disappeared. This fullness recurred, and she felt she couldn't hear out of her left ear on the phone. A week before her presentation, she woke up with aching pressure-like pain in the left ear, increased ringing and decreased hearing, and a sudden onset of a vertigo episode that lasted up to 3 hours. Symptoms almost completely subsided the next day. There was no personal or family history of migraines. Obviously, this is a typical case vignette of Meniere's disease. And it's interesting to see that sometimes you have the truncated symptoms before the full-blown attack that would declare Meniere's disease. On physical exam, she had a normal otoscopy, her Weber lateralized to the right. She had no spontaneous nystagmus. She had a normal head impulse test. She did have a right beating after head shake test, which points toward a potential weakness in the left ear, vestibular function. She had normal postural control on Romberg and negative Dix-Hallpike. So the next best step would always be to get an audiogram. When you have such a typical presentation, an MRI is not the next best step. There's no indication that she may have an autoimmune inner ear disease to activate all of those lab tests. And a VNG will not give you much more information than your clinical exam already did. So on her audiogram, she had a low to mid frequency hearing loss in more than 2 consecutive frequencies, more than 35 dB thresholds. Those are the Berenice Society criteria. So the Berenice Society criteria, you have to have on the audiogram a low to mid frequency hearing loss on frequencies below 2000 hertz in 2 consecutive frequencies and a threshold above 35 dB, which she clearly meets. Do you need an MRI? That's a question that always comes up. When you have such a typical presentation, I usually do not get an MRI. If she had more of an asymmetry in the high frequencies, of course, we would have gotten an MRI. But with this typical clinical picture, we can hold off. A caveat to this, that we started doing in our center the MRI with the delayed contrast to look for endolymphatic high drops. So probably now I would get an MRI with the endolymphatic high drops, since we started doing it 6 months ago, just to get a better idea of the fluid, of the extent of vestibular high drops that she may have, and as an adjunct for the diagnosis. No laboratory testing would be necessary at this time. And optimally, in this specific case, so she just presented with you with the first ever episode of Meniere's. We were lucky enough to capture it on that first presentation, but the reality is Meniere's disease is, you can rarely, identify it from a first attack. Most of the time, the hearing loss would have recovered by the time you see them. But in this specific case, she was very classical, and we started, of course, on the low-salt diet. And from the previous lecture, we talked about the options of treatment could include diazide and beta-histine. In my clinical practice, I always start with the low-salt diet. I rarely start immediately with diazide or beta-histine. My experience was that patients who do well on a low-salt or a controlled salt diet usually have good prognosis, and they don't need more aggressive management. So we all know the peripheral vestibular anatomy and the physiology behind Meniere's disease. The central point is the presence of endolymphatic high drops. A lot more studies are showing that the high drops may be an epiphenomenon rather than the cause, but it is present in virtually every single case of Meniere's disease when we use the imaging technique of the delayed contrast. Basically, most patients who fulfill criteria for clinical Meniere's disease will have a high drops on the MRI. We can also see the high drops in other clinical pictures like vestibular migraine or or even vestibular schwannoma or vestibular neuritis. It has been reported, but at a much lower percentage. We have to remember that the inner ear is very active physiologically, and it has all of those ion channels that are implicated in its physiology. One of the most important one is the aquaporins, which is currently among all the theories for idiopathic Meniere's. There's a lot of studies that are showing the role of aquaporins in the physiology or the interior milieu of the inner ear, of the endolymph physiology. And there's a lot of studies that are suggesting that mutations or dysregulation of the aquaporins is responsible for the onset of the Meniere's disease pathophysiology. We currently are doing a clinical trial using venlafaxine in a double-blind randomized control fashion to test its efficacy with Meniere's disease, basically based on that pathophysiology mechanism, because venlafaxine actually changes the aquaporin receptors or stimulates the aquaporin receptors. So a quick review of the Berenice Society criteria for Meniere's disease. We have the definite and the probable, and in order to diagnose somebody with definite Meniere's disease, they have to have 2 or more spontaneous episodes of vertigo lasting between 20 minutes and 12 hours, with audiometrically documented low to medium frequency sensorineural hearing loss in the affected ear on at least one occasion before, during, or after one of the episodes, as well as fluctuating oral symptoms in the affected ear. Obviously, if we were to enroll that lady into a trial, we couldn't enroll her as a definite Meniere's disease because she's only had 1 episode of vertigo so far. So moving on to case 7, it's a 57-year-old patient with a chief complaint of episodic vertigo, right-sided hearing loss, right-sided tinnitus, and right oral fullness for the past 2 years. The duration of the episodes was 30 minutes with full recovery between episodes. She would have 1 episode a week. She was diagnosed with Meniere's disease, treated with low salt and diazide. She did have a history of headaches, and these worsened when she started the diazide, so she stopped it. And 6 months before she presented to your clinic, she started noticing a different type of dizziness. She would call it as disequilibrium, off-balance sensation, different from her prior vertigo episodes. She describes it also as a rocking sensation that increases when she would lay down, often associated with headaches. Bending her head forward, physical activity, worsened symptoms of nausea and veering of gait to the right. One of her episodes was preceded with a visual aura, and she has a family history of migraine in one mother and a dizziness in a maternal uncle. So, this is also a very neat case that shows the interplay between the diagnosis of Meniere's and migraine. So she has both conditions based on the clinical exam. These are the 2 suspicions we have. On physical exam, she has a neurological and otologic exam that is normal. She has no spontaneous nystagmus. She has a normal head impulse test, a negative Dix-Hallpike on the left, although she said she feels dizzy when she would lay down. On the right, Dix-Hallpike patient got a little bit dizzy, but there was no nystagmus, and she didn't describe it as a vertigo. On the foam pad or compliant foam, to reduce some of the proprioceptive input, and usually your physical therapist would do this, she would get dizzy and unsteady, but did not lose her balance. So the question that one can ask was, does this patient have an associated BPPV? And quite often, this is probably a patient who is going to be sent to you for BPPV because she gets dizzy when she lays down. But she may have BPPV. There's no confirmation on your exam. And the kind of the teaching point here, you would diagnose BPPV usually only with a positive Dix-Hallpike. You can definitely suspect it at times, but if it's not a positive Dix-Hallpike, you shouldn't make a diagnosis of BPPV. The other teaching point is BPPV is associated with other comorbidities quite often. So, yes, you do have the isolated BPPV patient, and it is frequent. However, in patients with Meniere's disease and vestibular migraine, BPPV is twice as common as in the general population. So I tell the residents always, even if you have a confirmed diagnosis of Meniere's or a confirmed diagnosis of vestibular migraine, in your initial assessment, always lay the patient back and make sure there's not, on top of this, an associated BPPV. It takes a couple more minutes from your time. On laboratory testing, or audiology testing, she had a right low frequency sensorineural hearing loss in line with her right Meniere's disease. She also had a reduced VEMP on the right, C-VEMP and O-VEMP on the right side. She had a normal MRI, and the reason here, yes, she had a very classical picture of Meniere's, but she had those additional symptoms that are pointing to a vestibular migraine. So I wouldn't shy away from getting an MRI in this case. She also had a 35% caloric weakness on the right. Usually the cutoff is around 25% in most labs to call a caloric weakness significant. So the main point in this condition is you cannot pick and choose which condition to treat. If you want to give the patient the best outcome, you need to treat both conditions. And both conditions, you can treat them on a sliding scale of least to more aggressive. Obviously, for both, she was already on a low-salt diet, and she was placed on a diuretic, the diazide. However, diazide causes some dehydration, and dehydration is a trigger for headaches and for migraines. So either she wasn't taking it appropriately, meaning she was not hydrating enough, and you can do another trial, or you just, move away from the diuretics, institute the low-salt diet. If she's having a lot of Meniere's attack, which she's having about once a week, I would usually go to a transtympanic steroid treatment just to do the IT steroids, try to reduce the frequency or severity of her Meniere's attacks. In the meanwhile, I'll start her on a migraine diet and ask her to start keeping track of her symptoms. And once we finish the steroid treatment, I immediately would start her on a migraine treatment if her headaches are still happening more than once a week. And in her case, you can start her either on nortriptyline 20 milligrams at night. I usually start with once at night, and then after a week go up to twice at night, 2 capsules at night. If she's overweight, I'll probably go with Topamax and escalating it from 25 milligrams per day over the course of 4 weeks to go up to 50 milligrams twice a day. So week 1, 25 milligrams at night, week 2, 25 milligrams BID, week 3, 25 milligram in the morning, 50 milligram at night, and week 4, 50 and 50. Other options, if there's a lot of anxiety, I'll go with venlafaxine, 37.5 milligram per day. Or if she has some blood pressure issues, or if her heart blood pressure is adequate and not on the low side, we can try propranolol and verapamil. Again, I always say that in my practice, it's very difficult for me to add blood pressure medications because those patients, because of our environment, those patients already are on a lot of blood pressure medications or are already on a calcium channel inhibitor or a beta blocker. So my trifecta, I would say, would be nortriptyline, venlafaxine, and Topamax. So the question that begs itself, are migraine and Meniere's disease different spectrum of the same disease? There's a lot of ink that was spilled on this. When we look at the consensus document classification of vestibular migraine, you can review here the criteria. You have to have at least 5 episodes of vestibular symptoms of moderate or severe intensity lasting between 5 minutes and 72 hours, current or previous history of migraine with or without aura, 1 or more migraine features with at least 50% of the vestibular episodes. And those migraine features can be a headache with a migraine quality, photophobia and phonophobia, and visual aura. The link between Meniere's and migraine was actually first described by Prosper Meniere himself. In his initial report to the Gazette Médicale in the 19th century, he said, I have a sense that all of those patients that I'm describing have a high prevalence of migraines. And already at the time, it was a hard pill to swallow that vertigo can come from the inner ear. So he was already being dismissed by his peers for this. And then again dismissed because he was saying that this could be a form of migraine. And then it took until the year 2000 with this very neat study done by the Berlin Autology Group to show that the lifetime prevalence of migraine in patients with Meniere's disease is very high. So up to 56% of patients with Meniere's disease have a current or a past history of migraines, whereas the general population is 13%. And in women, this ratio or this prevalence goes up to 75%. The prevalence of a vestibular migraine in one neurootology clinic in Europe was described as going up to 16%, which is, if you know, everybody who treats dizzy patients knows that this is even maybe an underestimation of the amount of people who fulfill criteria for probable or definite vestibular migraine in an ENT clinic. And it's whenever I talk about this, I kind of put this caveat that migraine has so many manifestations in ENT that we need to be aware of. One main manifestation is sinus pressure. So 80% of patients in this study that was published in the Archives of Internal Medicine, about 80% of patients with a self-diagnosis of sinus headache fulfill criteria for migraine headaches, according to the neurologist who published that study. Another study looked at how our professional, depending on our training, how sometimes we look at things in a different lens. They presented clinical vignettes of patients with headaches to a group of allergists, a group of ENT, and a group of neurologists. The same case vignette, 83% of neurologists diagnosed them as migraine headaches, 54% of ENT diagnosed them as sinus headache, and probably they were looking for a chronic sinusitis or going down that path, and 38% of allergists diagnosed them with sinus headaches. But basically, rule of thumb numbers, and that I tell residents all the time, is up to 70% of sinus headaches are undiagnosed or atypical migraines. Of course, if you have enough symptoms to suggest that this could be a sinusitis, you should, do the nasal steroids, the nasal lavage, get a CAT scan. But if you have minimal sinus disease on the scan and patient is complaining of sinus pressure and there's not a convincing finding of chronic sinusitis, think about migraine, treat them or refer them to a neurologist who can treat them. The other point that, that is a little bit more recent, some studies are trying to find if there is a differential cytokine profile that could distinguish between vestibular migraine and Meniere's disease. If we look at the type of phenotypes that Meniere's disease patients can present with, we can separate them into 5 clinical subgroups. There's the group of Meniere's who present with sensorineural hearing loss in one ear, followed by a contralateral ear after several months or years. Group 2 presents with simultaneous hearing loss in both ears at onset. Group 3 is the case of Meniere's patients who present with a very strong and confirmed first-degree family history of Meniere's. Group 4 comes associated with migraine, not vestibular migraine, with migraine headaches. We all have the Meniere's disease patients who have no migraines, but there's a group of patients that present with strong association with migraines, and group 5 that presents with autoimmune disease. This study that was done by the Meniere's Disease Consortium in Europe looked at 129 patients with definite Meniere's, 82 patients with definite vestibular migraine, and 66 healthy controls. They withdrew, the peripheral blood and processed them with centrifugation to extract the PBMCs, the peripheral blood mononuclear cells. They did look at RNA extracts, but also measured in the supernatant cytokine levels, and they looked at all of those cytokines listed here. What they found is vestibular migraine patients, clinically, vestibular migraine patients were younger than Meniere's disease and had an earlier onset of disease. Meniere's disease patients had worse hearing, higher number of vertigo attacks, and worse functional assessment. The Meniere's disease patients who had a low rate or low levels of interleukin-1 beta had more autoimmune disease. The Meniere's disease patients who had high levels of interleukin-1 had more drop attacks. There was a differential genetic expression profile when they looked at the RNA between the vestibular migraine and Meniere's disease. And however, they also had some similarities. Basically, the more significant difference came from the chemokines CXCL22 and CXCL10 that were highest in vestibular migraine compared to Meniere's disease. The bottom line, that study is trying to show that there's a biological difference between the two pathologies. especially with the ones with the Meniere's disease patients who have high levels of IL-1 beta. So, it was one of the first studies that basically showed that there's a difference at the molecular level and the gene expression level. When they looked at the subtypes of clinical Meniere's, the type 4 that presented with migraines actually had earlier onset when it was compared to the other phenotypes of Meniere's, and it was the closest clinically to the vestibular migraine subgroup. So what we need to kind of take away from that study is that Meniere's disease is not a single disease, it has various endophenotypes. We are using clinical classification, we are using imaging to try to differentiate them, and possibly in the future, the cytokine profile may give us even more information. The detection of the cytokines in the PBMC supernatant suggests that in both cases, there is a systemic inflammatory reaction. That's why a lot of those patients, when they have an attack, they respond to a steroid that you give orally. It can also explain potential prolonged inflammatory response leading to inner ear damage, whether it is with Meniere's disease or in some cases of vestibular migraine. And finally, the authors of that study suggest that Meniere's disease can be, rather than being an autoimmune problem, can be an autoinflammatory disorder, which is a subtype of rheumatological disorders that can cause that are due to a hyperactive inflammatory response rather than a true autoimmune antigen-antibody response. So moving on to case 8, it's an 87-year-old patient who presents with complaints of drop attacks. He has coronary artery disease, takes multiple blood pressure medications as well as Flomax for his prostate issue. He has had one episode of spinning in the past several years ago. He has decreased hearing and bilateral tinnitus. His drop attacks started 2 months before he presented to your clinic. He has had 6 of them so far, with one leading to a small injury. All of his testing was normal: CT, MRI, CTA, EKG. So by the time he was seen by us, he had already been ruled out or evaluated by neurology and cardiology. And on physical exam, he had no spontaneous nystagmus. He had a positive left head impulse test. And after head shake beating to the right, suggestive of a left vestibular hypofunction. Orthostatic vital signs did not show any drop in blood pressure of more than 20 millimeters of mercury. We did some laboratory testing that showed a left vestibular hypofunction on the caloric exam, mild central signs correlated with aging, absent VEMS bilaterally, which is not unusual at his age. However, given the pattern of the symptoms, the fact that he has had a history of vertigo attacks on one side a few years ago, and the fact that he has a hypofunction on one side, we made a tentative diagnosis of a Tumarkin crisis, which is a drop attack in the setting of Meniere's disease. And in order to preserve as much function as we can, we proceeded with IT injection of dexamethasone to his left ear and started him on a low-salt diet. That patient is now about 5 years out, and he has been symptom-free since then. So, it could, and it is still the most likely diagnosis that he's had, that this is a Meniere's disease. And the caveat is that there's a few studies that show that when Meniere's disease presents de novo after the age of 65, it has a higher likelihood of presenting with the more severe form, which is Tumarkin crisis. So Tumarkin crisis is also called the Autolytic Catastrophe. Tumarkin is the name of the British physician who described it in 1936. And if you read the initial case vignettes, it's actually quite interesting to see, the first case that he described and that he related to the utricle. Mr. X was standing at his desk talking to a client when suddenly he slumped to the floor. He had no vertigo, no loss of consciousness, and no malaise. The thing came like a bolt from the blue, but he was immediately able to assure onlookers he was all right and almost immediately got up and carried on. So clearly no loss of consciousness. It's a sudden loss of tone of all the truncal extensor muscles, which communicate with the utricle through the vestibulospinal reflex. At the level of the saccule, if you have a saccular drop attack, the account is slightly different. Those are the patients who present with a sensation of being shoved to the side, like Mr. Y, who was standing in his van receiving packages when suddenly he felt as if the wheel had collapsed under him and he crashed down on his side. Obviously, if you have a 65 or a 70-year-old who has something like that, their likelihood of getting hurt is high. And the drop attacks are hypothesized to be due to a sudden shift of force at the level of the utricular macula, sudden changes in the endolymphatic pressure at that level, or a sudden electrolytic change from rupture of the membranes at the level of the utricle and saccule macula. This is a video that shows a Tumarkin crisis in a different setting, that's why it's recorded. It was done after an epley, and it gives you an idea of how violent this could be. I'm going to skip through to the end of the epley. So this is a patient after the epley and after the otoliths were repositioned. They went down into the vestibule, and in her case, they hit down against the utricular macula. That's the most likely explanation. And that sudden change in utricular pressure caused loss of tone of the truncal extensors of the muscle, of the extensors of the trunk, and led to her having a drop attack that was recorded. And that's something to always keep in mind if you're doing an epley. Even when you sit the patient up, stay close to them for about 30 seconds at least. Another atypical form of Meniere's is called Lermoyes syndrome. And this is more like a curiosity than a true clinical differential problem. Lermoyes is Prosper Meniere's student, and he described in 1919 somewhat different presentation to those patients. Those are patients who had true vertigo with improvement of hearing. So, and you might see it in patients who have the classical Meniere's, but sometimes some of their episodes will present like this. Basically, they will lose the hearing, and as soon as they have the vertigo, their hearing will improve, rather than the hearing worsening with the vertigo and then taking a while before getting better. There wasn't, it's very difficult to test patients, obviously, when they are in the middle of a crisis. So we don't have clear, distinctive features, but everybody, we all think that this is part of the same pathology and doesn't call for any differential treatment plan. So the treatment of Meniere's disease, the acute attack has to be treated. You have to empower patients to be able to proceed and not have to go to the ED, especially now with COVID. That came even more true to try to decongest the emergency rooms. And when you see a patient present, I've had the misfortune of seeing patients with Meniere's disease in clinic. Like they go from a 0 to 100 in the matter of seconds, and there's no coming back from it. You have to wheel them out of the clinic and get them, at this point you have to give them something, to antiemetics, sometimes IV, to improve things. So when they start knowing when their attacks are going to start, they can pre-medicate. Preventive medical treatment, low salt and diuretics, IT steroids, SAC surgery if they still have good hearing and they don't want to go into more aggressive measures. But then if they fail all conservative measures, gentamicin and labyrinthectomy are last resort. Case 9, and in case 9 there will be about 4 case 9s because they are all a subgroup of patients who are older and presented with kind of a similar audiogram and similar presentation, but had completely different diagnoses. So this is an 84-year-old patient with a history of left profound sensorineural hearing loss for a few years before he presented to us. 6 months before his clinic presentation, he developed a violent vertigo attack. And on clinical exam, the day of the consultation, he had a right beating. So 6 months after the vertigo attack, he had a right beating nystagmus in all directions of gaze, so signifying in favor of a left weakness, positive left head impulse test in favor of a left vestibular hypofunction, and a right beating after head shake nystagmus in favor of a left hypofunction. And his hearing loss was profound on the left. A caloric exam showed a 63% weakness on the caloric response. Rotary chair showed low gain and phase lead in the sinusoidal harmonic acceleration protocol, where we put the patient in a chair and start turning them around 180 degrees in a steady state fashion. And we record how the eyes are moving. If there's a phase lead, then you know there's a vestibular dysfunction. His head impulse test showed saccades in all planes of movement, but more noticeable in the lateral planes, left and right. The gain here is not very well, you cannot read it very well, but it's very small, about 0.25, if I'm not mistaken, on the left side. We ordered an MRI given his profound hearing loss, and you can see he has something lighting up in the cochlea and in the vestibule. We went back to 2014 when he had his sudden hearing loss, and he had this tiny speck in the cochlea. So this is a patient who had a cochlear schwannoma, and several years later, he developed a vestibular schwannoma. A repeat MRI showed, since then he's had serial MRIs that showed continued growth of this schwannoma. Patient has done better with PT for his symptoms, but has consistently refused to get a labyrinthectomy. He has no hearing in that ear, but a labyrinthectomy can easily access the vestibular component. And at this point, it's unlikely that it will cause a huge issue in his lifetime. He's 84, now probably 88. The other interesting point is there are reports of intravestibular schwannomas, but what's interesting is that it seems like he has two separate schwannomas. There's no communication between the cochlear one and the vestibular one on the multiple MRIs we've had so far. I always take a small aparté here and aparté and talk about the MRI in the setting of dizziness. I always tell residents, look at the T1 with contrast as well as a Fiesta sequence. And a lot of times you're going to get the outside MRIs with not a great cut over the IAC because they didn't do a posterior fossa protocol. And you can easily miss, like in this case, you can easily miss it on the axial T2, but it's very visible on the axial T1 with contrast. It's a completely different case than the one I presented. I'm just presenting the MRIs. Again, here you have the axial Fiesta that shows very well the tumor on the right side. On the left side, you have a flare sequence which shows it, but using the Fiesta and the T1 with contrast is very helpful. So this patient proceeded with vestibular rehab. We considered labyrinthectomy since it's a fast-growing tumor. It grew about 5 millimeters in 3 years. I mean, slightly higher than what you would expect per year. But he's consistently refused to proceed with it and wants to rather observe it, which is a very reasonable choice as well. So case 9B is a 73-year-old male patient with sudden onset of vertigo with nausea and vomiting. He is on Coumadin for AFib, and he was not taking his Coumadin appropriately around the time this happened. His INR dropped to 1.5. Neurological exam normal, except for a right beating spontaneous nystagmus. He goes to the ED, and they get a CAT scan that is normal. He follows up with neurology. He's already less dizzy by day 2. They order an MRI. There's a small infarct of the right occipital lobe. Cannot explain his symptoms. So he was sent to us. Evaluation was normal except for a positive left head impulse test and an after head shake beating to the right. He had a caloric deficit of 100% in the left ear and a normal audiogram. He has a history of a left amaurosis fugax 6 months prior to his presentation. 3 weeks later, he complains of typical BPPV and is treated with Epley maneuvers. Still imbalanced. We sent him for a course of vestibular rehab. After 6 weeks of rehab, his caloric response improves a bit, 54% weaker on the left side. His rotary chair gets in line. There's no phase lead if you look here. His smooth pursuits, even at his age, are very good. There's no saccadic smooth pursuits. Same thing for his for the saccadic tests. He has an absent, no, he has normal CVEMs. They're absent at the lower threshold, but at 95 dB, they're normal on both sides. He does have a hypofunction on the OVEMs with 62% asymmetry on the left, being weaker than the right. So that tells us that the saccular or the inferior branch of the nerve is intact, and the utricular portion, which the OVEM tests for, has been affected by this event, which could be a neuronitis. However, given his history of AFib, Coumadin that was not under control, the fact that he had an occipital infarct in the posterior circulation makes us think of a slightly different problem. It's called the anterior vestibular artery syndrome. It's like a small stroke in the ear. It's extremely hard to diagnose, and unless you have a high degree of suspicion at the time of the presentation, you have to tell your radiologist, look on the MRI, see if there's any lack of perfusion through the labyrinthine artery, and it's very hard to detect. But it's something to think about because you can easily dismiss it as a neuronitis, and that patient would have, if he's not very compliant, he's not following with his GP or his cardiologist, it can go under the radar and doesn't do well because his Coumadin is not well checked. But if you raise the alarm that this could be an issue that is related to blood flow, you can help get him in the right place to get his cardiovascular risk factors controlled. And as a quick review of the vascularization of the inner ear. So in most cases, the labyrinthine artery comes from the ICA and then divides into the anterior inferior artery and anterior inferior vestibular artery. I'm sorry, the ICA comes from the basilar artery and then gives the labyrinthine artery, which gives the anterior vestibular artery and the common cochlear artery. The anterior vestibular artery follows the course of the superior vestibular nerve and basically vascularizes the anterior and lateral semicircular canal cupula, as well as the utricle. The common cochlear artery divides into the cochlear artery proper that goes into the cochlea, and the posterior vestibular artery that goes into the posterior canal and the saccule, following the inferior vestibular nerve. So case 9C is a 76-year-old female patient with sudden sensorineural hearing loss on the left side. The onset of hearing loss was following a neck massage. She also notes mild dizziness at the time of the event, as well as a loud left tinnitus. Her MRI was ordered. She had an infarct of the right post-central gyrus that cannot explain her symptoms. She comes to ENT 4 months after the event that led to her hearing loss. Since then, she had had 5 episodes of dizziness lasting more than an hour. She had a left spontaneous nystagmus grade 1, meaning beating to the left only when she looks to the left. She has an abnormal smooth pursuit, abnormal saccades. She has an after head shake nystagmus beating to the left and a positive left head impulse test. So her hearing test shows clearly a significant hearing loss on the left side with 24% word rec. Her caloric are 48% weaker on the left. Her rotary chair shows that there's no phase lead, so her vestibular hypofunction is getting compensated. She did have a lot of saccadic smooth pursuits, completely different from the other smooth pursuit tracing that I showed you. On posterography, she fell on conditions 5 and 6, and these are the conditions where the patient has to rely most on their vestibular input. Basically, here we are moving the platform under their feet, and they are blindfolded. And condition 6, we are moving the platform under their feet, and we are moving the visual field they are looking at. So that patient has more than likely a posterior vestibular artery syndrome. So she had a severe neck manipulation that led to a sudden hearing loss and a vestibular hypofunction at the same time. And if we follow the vascularization that I just talked about, more than likely her reduction of blood flow happened in the common cochlear artery that led to disruption of flow in the posterior vestibular artery and the cochlear artery proper. For some reason, we didn't do a VEMP here, but I would expect her CVEMP to be absent. And case 9D is a 77-year-old patient with multiple comorbidities, congestive heart failure, AFib, peripheral artery disease, and COPD. He presents with new onset of vertigo every time he looks down. His balance has worsened in recent months, but he only consulted when the vertigo started. He has a history of profound sensorineural hearing loss in the left ear following a Q-tip incident 10 years ago. He notes he got very dizzy as well at the time. He also notes that his hearing came back for a few years and then completely went out 5 years ago. He describes hyperacusis and sensitivity to sound. He has no functional hearing in that left ear. No spontaneous nystagmus, saccadic smooth pursuits, which is correlated to his age and his comorbidities, a positive left head impulse test signifying a left hypofunction, a right beating after head shake nystagmus, also in favor of a left hypofunction. Now, on Dick's Tolpike, I'm going to show you the, he has, interesting eye movements. You can see on the left Dick's Tolpike, he has a downbeat nystagmus, downbeat torsional nystagmus. On the right Dick's Tolpike, he continuously has an apogeotropic downbeat torsional nystagmus. So that was a little bit unusual. I mean, is it the superior canal BPPV? Is it the bilateral posterior canal BPPV? Is it a posterior BPPV where the crystals were stuck in the non-ampulated arm or behind the cupula, which can cause an apogeotropic form of eye movements? Or it could be a central problem, obviously. Now, it was clearly positional. His symptoms were clearly positional, and the exam was showing a clearly positional eye movement. See here. You can see here the downbeat eye movement in the right Dick's Tolpike. And depending on his gaze, you can see more of a torsional and more of a vertical component. And on the left, also continuously beating to the left, torsional with a downbeat component. So what are possible diagnoses? I mean, all of the above are possible, but usually the simpler explanation is the best one. He does have evidence of a left hypofunction, and it is clearly positional. So more than likely, he has a left hypofunction with a superior canal BPPV. And we went with that assumption. We decided to do repositioning maneuvers for the superior canal BPPV, and multiple ones did not work. So we got an MRI that came back completely normal, no lesions, no stroke, an incidental meningioma. And this led us to review the criteria for a superior canal BPPV. So a superior canal BPPV has to have an apogeotropic horizontal torsional downbeat nystagmus on Dick's Tolpike, brief latency, rapidly fatigable, which is not the case here, reverses upon sitting, and we'll see it later, it does reverse, and it points to the uppermost ear. So when he laid down on his right, it was apogeotropic beating toward the left side. So that was in favor of a left superior canal BPPV. But you always have to be careful when you have those unusual nystagmus and get an MRI, make sure you're not missing anything. So the MRI was reassuring. We felt it was BPPV compounded by the left hypofunction component. We eventually were able to clear his dizziness when he looks down, but he still had a nystagmus in the Dick's Tolpike position. On caloric exam, despite the Q-tip incident, he had no weakness that is detectable on the caloric. His rotary chair shows a phase lead and a low gain. The posterography shows falls in conditions 5 and 6 in favor of a vestibular pattern. His OVEMP showed a large amplitude, 76% on the left compared to the right. Given the Q-tip incident, one might think this could be a perilymphatic fistula, but he failed the fistula test. On CVEMP, he had a reduced threshold on left CVEMP, down to 65 dB. He had a present response on the left side. And VHIT showed significant weakness with a gain of 0.58 on the left lateral head impulse test and a gain of 0.21 on the left superior head impulse test. And we repeated all the positional testing, and we still had this downbeat torsional nystagmus. I'm going to skip over that component. Basically, on the right Dick's Tolpike, he had And so that was after several weeks from the initial presentation. When we recorded it, he had a regular posterior canal BPPV picture with an upbeat torsional nystagmus and would reverse direction upon sitting up. On the left Dix Hallpike, he had a right beating nystagmus upon sitting up in favor of his hypofunction. So, we never really got a clear answer for this patient's symptoms. Some of the VEMP studies are suggestive of a potential superior canal dehiscence. Given his comorbidities and atypical symptom profile, we were not going to do any surgery on him. So I did not pursue a temporal bone CT. And, in this case, the impression was that this is more likely a type of autolytic disease. So there were some otoliths that were dislodged in various parts of the inner ear that were causing all those interplay and unusual nystagmus. Could he have a central positional vertigo? It is rare, and it is usually related to a structural lesion of the cerebellum, the nodulus, or the uvula. But rule of thumb, if you have a downbeat nystagmus when you lay the patient back, look for an Arnold-Chiari, because that is one of the main causes you can find. Look for strokes or MS lesions in the brainstem. And finally, I'll find this, this notation interesting. It's listed on the Timothy Hayne website, which is a great resource to look at all types of vestibular disorders. And the title of the article is, "How could canal plugging result in intensive direction-changing type of positional nystagmus?" And after a severe vestibular disturbance where parts of the inner ear function is lost, the brain attempts to compensate, and sometimes this involves using of motion sensors in the inner ear for a different purpose than the original one. So those are the patients who are encountered with impossible nystagmus. And it's similar to the synkinesis or to the Frey syndrome, where there's a rerouting of nerve fibers in a place where they shouldn't go. And sometimes that's what happens. And that guy had a severe trauma to his inner ear with the Q-tip incident. His hearing came back after several years, so there was some regeneration and recalibration at the level of the brain. So I guess the teaching point of that case is, don't take for granted a positional nystagmus. It is not always BPPV. Think of central components. However, if you have a downbeat torsional nystagmus that reverses upon sitting up and you're confident, it could very well be a superior canal BPPV. You will rarely see this. It's less than 1% of the cases. You can attempt a repositioning maneuver, and if the patient is compliant, before sending them for an MRI. Truth of the matter is, most of the time, they're going to have an MRI before getting to you. So re-examine the patient frequently is also an important teaching point with this. Case 9E is an 80-year-old male patient with a complaint of imbalance and episodic vertigo. Vertigo spells last 1 minute and happen with position change. He lost his hearing in the left ear suddenly several years ago. And on exam, he has a positive left head impulse test, profound hearing loss on the left, and an MRI of the IAC actually shows nothing on the axial T2. On axial T1, he had a vestibular schwannoma. Very quickly, a 21-year-old male patient with a 2-month history of a rapidly progressive bilateral asymmetric sensorineural hearing loss with reports of a few spells of vertigo lasting 20 minutes with nausea and vomiting. Responded briefly to prednisone, developed a rash on his upper extremities and trunk. His MRI was normal. This was his audiogram upon presentation. He had a positive ANA, normal SED rate, but a positive VDRL and a confirmatory test for syphilis that was positive. So that patient had otosyphilis. He was also diagnosed with neurosyphilis and a co-infection with HIV. And his sole presentation, apart from the rash, was his rapidly progressive bilateral hearing loss. He was treated with IV penicillin. And case 11 is a 61-year-old patient who presents with a 2-week history of significant imbalance. Although he denies vertigo, he describes a sudden onset of a sensation of feeling drunk and walking off balance, which has improved some but persisted. He also notes a rapid decline of hearing bilaterally. His physical exam is in favor of a left vestibular hypofunction. That was his hearing loss upon presentation, bilaterally, moderate to severe hearing loss, worse on the left side. Review of history shows he's on prophylactic meds for STD, so we ask him about syphilis. He says he gets checked every 3 months, and he was notified that he was positive for syphilis the day of our visit with him. We confirmed the syphilis infection in our lab. He was worked up for neurosyphilis. It came back negative, and his MRI was negative for retrocochlear pathology. He responded to high-dose prednisone, 60 milligrams QD for 10 days, and then IV IM penicillin for a month. He did have some recovery of hearing and improved symptoms, but after 6 weeks when he returned, he had noted return of some of his symptoms. ID had cleared him from the infection. His hearing was maybe slightly improved, but the word rec was down. Vestibular testing confirmed left hypofunction. He was placed on prednisone. Vestibular rehab initiated, and we don't have more follow-up. That was a very recent case. Basically, the teaching point here that syphilis is actually, there's an epidemic of syphilis, especially in the Southeast, and I never thought that I would see syphilis presenting with otologic symptoms, but here it is. Those are at least 2 cases with separate demography that presented with, I wouldn't say similar, but interesting symptoms. And the last case of the day is a 56-year-old female patient with a chief complaint of a 3 month of dizziness and disequilibrium. She describes discrete episodes of vertigo, rapid heartbeat, faintness, cold sweats, anxiety, and visual blurriness. Her episodes last 5 minutes, but then are followed by a sensation of feeling swimmy-headed, a brain fog, unsteadiness, and nausea. She does have fluctuating bilateral tinnitus and oral fullness, independent of the vertigo attacks. She does describe headaches, but they're not migraine. They're not necessarily her typical migraine. She describes a pressure sensation, electric-like shock sensation in her scalp. She does have light and sound sensitivity and paresthesia around her lips. She describes visual vertigo. She avoids shopping malls and grocery stores. She cannot drive over a bridge. Her past medical history is indicative of fibromyalgia and IBS. All of her exam is normal, except for an increased sway without any falls on compliant foam. She could not tolerate the caloric testing, the rotary chair. She had a previously normal MRI of the brain. The most likely diagnosis, she does have some symptoms suggestive of migraine, but if you look at the entire picture, this is a lady that kind of fulfills the criteria for persistent perceptual postural dizziness, PPPD. And the treatment, and the Berenice Society issued some criteria for this. The criteria being, you have to have the symptoms for more than 3 months. You have to have the symptoms more often than not throughout the day, but not necessarily 24/7. Your symptoms have to be exacerbated by your own movement, by movement of people around you, by visual stimulation. So in this case, you start lifestyle modifications, you do a lot of education. I usually start them on Effexor, venlafaxine 37.5, sometimes clonazepam, but rarely. And I talk with them about CBT and support groups. It's important that they acknowledge the problem so that they start working on it. And we also use vestibular rehab very gently because they are very motion sick and they are very anxious. So PT is going to basically teach them how to walk again. One way I explain to patient what they're feeling like, there's a breakdown in the smooth and coordinated way that usually one walks. And I equate it to driving a car with your handbrake still up. It's not going to drive very smoothly. And we need to release that handbrake. That's what the medication would do. And we need to teach you how to drive again. That's what the PT will do. And a lot more data to review on the slides for this. But this is a very real condition. It's not psychogenic. And as ENT, you will undoubtedly see those patients. And you can choose to just, pass them on, or you can get them started and refer them to somebody who can help with their medication management. And on this, I will end and give the mic back to Mallory. Thank you for listening.
Thanks, Dr. Rizk. That was awesome.
Thank you.
I had a question about one of your first cases, kind of tying into the second one. If I recall right, the patient had a pretty classic presentation in Meniere, but it was the first one, and a significant hearing loss. It might be tempting to offer intratympanic steroids at that time because of the hearing loss. What do you think about that?
I think it's very reasonable. But she was still fluctuating, but I'm not sure what the timeline was when she presented to me, if I considered it too late, but more than likely I either gave her steroid like at the time or discussed it with her. But yes, if they present, my rule of thumb, if a Meniere's disease patient that is established presents with a hearing loss that has not reversed in more than 24 hours, I suggest steroid to them.
Okay, that makes sense.
Hi, Dr. Rizk. Hi, this is Eric Formeister.
Hi, Eric. How are you?
It's nice to see you in person. I know we've
Yes.
We work with Dr. Schron a lot. Sorry, I showed up a little bit late, but these are all super interesting cases. And just as someone who sees a lot of dizzy patients, I'm having just come from clinic and now sort of probably saying this spiel 3 times today. I was wondering if there's any data or what your experience is with people who have vestibular migraine and sort of have a history sort of decades ago, let's say, as teenagers, adolescents, and college years and or childbearing years for the female population, they go completely like stale with respect to migraine symptoms, no dizziness symptoms, and then sort of come on, decades later, and they're sort of basically satisfying criteria given the history of migraines and their sort of vague, chronic imbalance, brain fog, things like that. Do you see that a lot where the headaches are just gone, but then they're just, all of a sudden they had like a period of quiescence and now they're just sort of left with these dizziness symptoms?
Actually very frequent, especially in the female population of postmenopausal women. Mm-hmm. There's a lot of studies that are looking at the hormonal impact into this, and there might be a subset of vestibular migraine that are hormonally induced or hormonally sensitive. And the classical case is, the woman who presents at the age of 55 or 60. She's had a history of terrible headaches during teenage years, and then they went away when she got pregnant, when she delivered her kids, and then suddenly it comes without any headaches. But when you probe, most of the time, when you tell the patient take a diary and come back, they tell you I actually have headaches, but they're not on the foreground. So when they present to you, they're not talking about headaches much, but they fulfill criteria from the migraine equivalent, light and sound sensitivity.
Yeah.
Sometimes they have been diagnosed with ocular migraine along the way, but they don't have it very frequently. So those are patients where I would say you have a probable vestibular migraine, and we should treat it like a migraine and then reassess. But definitely I see it pretty often. And, I think vestibular migraine criteria are going to expand at some point. There's a big push for this to happen. As we understand more about the migraine mechanism and its interplay with the vestibular nuclei or the inner ear.
And then just while I have you, because I know you see a lot of this, and I'm just out of curiosity, we see a lot of vestibular migraine. That's probably half of Dr. Carey's practice, actually, because
vestibular migraine, yeah.
They also have an anatomic, dehiscence, which is not causing their symptoms.
Yes.
And we probably see that in there's actually not much data. Like the biggest, I think, series is out of Mass Eye and Ear, and they only have 40 patients, but I think it's 40% or 50% of overlap between SCD and and we easily see 50%. Even if they don't, we treat them like they do, and they get a little bit better before surgery. But in any case, is your sort of standard workup for VM, or I guess treatment algorithm, do you guys start with an intensive migraine elimination diet for 3 months plus supplements, and then start talking to them about starting low dose nortriptyline or amitriptyline, or do you have what is sort of your typical? I know that's sort of a loaded question, but I'm just curious.
For vestibular migraine, you talk about SCD, because I do have that impression. I mean, I always screen for migraines when I have an SCD image or clinic, and I would never operate on somebody who has uncontrolled headaches, because I learned that post-op they don't do as well. You know, and in my experience, the ones that have the best relief from their SCD symptoms are the ones who didn't have headaches, where I was certain 100% that all of their symptoms are related to the SSCD. Now, for my typical vestibular migraine protocol, there is the dietary the dietary element to it. I do have a nutritionist sometimes in my clinic, like half of my clinics I have a nutritionist, but she also calls my patients back and make sure they're being compliant or have questions. And I stress on hydration and on salt reduction. I do give them basically the two dietary changes for Meniere's and migraine. My go-to medication, I guess everybody has a preference at some point and is more comfortable with one drug than the other. For me, it's Effexor, and I used it so much that I think it works on Meniere's, so I'm trialing it in Meniere's right now. And it has, there's a little bit of a science behind that choice. So my Effexor is my go-to so far. Nortriptyline is kind of a close runner-up. And yes, sometimes the thing is, I think sometimes patients give up too easily on the medication, and I try to institute the need to try it long enough. I usually give them 8 to 12 weeks of medication before assessing if they're responding. And after 8 to 12 weeks, I may increase the dose. So like Effexor, I start at 37.5 and I go up to 75. Rarely go up higher, but I have gone to 112.5 and 150. Nortriptyline, 10 to 20, and then 30, 40, rarely beyond 50. Most patients either respond or don't tolerate. I do have a lot of obese patients. Again, we have a high incidence of IIH and CSF leaks, so we do see a lot of those patients, and I don't hesitate to use Topamax. So those are my go-to 3 medications usually. Propranolol I use sparingly, just because I cannot just fit it in the regimen.
Gotcha.
I do also do all of my patients, almost all of them, get an educational session with PT to start with, and if we detect some hypofunction, we start them on, we treat them for that if their headaches or if their symptoms are not too terrible, because otherwise they won't be able to continue their PT until you calm down the symptoms.
Gotcha. Cool. Thank you.
Sure. Valerie, I cannot hear you. You're muted.
Sorry about that. Thanks again, Dr. Rizk. That was a great talk.
Sure.
I think we'll end it there.
Okay, perfect. Have a good evening,
Thank you very much,
everyone.
Dr.